Thank you all for joining our talk tonight. Appreciate you taking the time out of your day and evening to listen in on a naturopathic approach to recurrent UTIs with Dr. Ashley Girard. I am just as a quick note for the agenda, we're going to do the presentation with Dr. Girard. After that, we're going to have about 15 minutes or so for questions and answers. So feel free to put your questions into the webinar chat or the Q&A box. After that, we'll do our raffle, which I'm sure everyone had seen. There's a raffle for those sticking around for the whole talk for a couple prizes. And lastly, if you want to hang out for about 5 to 10 minutes, I'll be going over some of the Utiva products if you're interested to hear more about that as well. I'm going to quickly introduce Dr. Girard here. So Dr. Girard is a naturopathic doctor in Ontario and the owner of Holistic Bladder Care, which is a telemedicine-based practice with a focus on female bladder and pelvic conditions that stem from her own struggles with recurrent UTIs and bladder pain syndrome. She collaborates with practitioners globally in order to help patients access effective treatment options with the goal of achieving a better quality of life with these conditions. She has additional training on hormone balance, digestive issues, thyroid diseases, and other chronic pain conditions. Dr. Girard is passionate about educating her patients, finding root causes of disease, and inspiring change that leads to healing. Without further ado, here's Dr. Girard.
Thank you very much, Derek. I so appreciate the opportunity to talk about what I'm extremely passionate about. My whole practice is dedicated to this, and I've been in this specialty for a few years full time, and since I graduated, I've seen a lot of bladder patients because you just bring these patients to you when you have that life experience with these conditions. So I will try to put as much as I can into this 30 minutes. Obviously, there's always more to know, and I hope to do more talks in the future. And you can always feel free to reach out to me. Like Derek said, I do collaborate with lots of practitioners globally to help patients, and just the whole goal is for patients to get better, right? And as I'll go through this, you'll start to see that recurrent UTIs is kind of one of those conditions that is falling a little bit in a crack in the medical system, which is similar with so many different women's health concerns. But yeah, I'll get more into that as we go. So thank you all for being here and taking time out of your busy schedules. And I hope you learned some great information tonight. So, all right, let's get started. So recurrent urinary tract infection. So we're just going to start with the basics, the patient population. Most of this is going to affect women. Women are the most frequently affected by urinary tract infections. Uncomplicated UTIs is going to be the majority of your patients. So this is women who have had less than 2 acute UTIs in the last 6 months, or 3 within the last year, 3 or more within the last year. And we are looking for that symptom resolution between infections or minimal urinary symptoms between infections. If we have a woman that has an anatomical abnormality or a functional abnormality, they're considered complicated UTI patients. Some other types of things that put patients into the complicated UTI realm: pregnancy, immunocompromised, if they have multi-drug resistant pathogens. So, when you're getting your antibiotic susceptibilities, if you see that there's a lot of antibiotic resistance, that actually makes them a complicated UTI patient. UTIs in men are always considered complicated as well. And when we talk about the lab diagnosis, we do really want to see that culture proven is preferable, and symptoms, urinary tract symptoms, lower urinary tract symptoms with pyuria. So elevated leukocytes on our urinalysis. If you're doing urine microscopy, we're seeing the white blood cells under the microscope as well. Now, the one thing I really want to emphasize is that there are problems with the standard urine culture, the SUC. There is estimates that it misses up to 30% to 50% of infections are missed. And that's why symptoms are king when it comes to a UTI. This is why, you've got lots of patients that are given antibiotics who have the symptoms, as long as it's a pretty classical presentation. So just keep that in mind, that, patients shouldn't be, the standard urine culture coming back negative doesn't necessarily rule out infection. We want to encourage patients to do really good cultures if at all possible. So midstream urine, first morning urine, and you do want to make sure you're looking at the right units. We have different units in US versus Canada. So unless you're paying attention, you might get a little bit confused. So here in Canada, we report an infection as greater than 100 times 10 to the power of 6 CFU per liter. And in US, it's CFU per mil. So that brings it down by a factor of 1,000, and the cutoff is greater than 100,000 CFU per mil is considered an infection. There is growing recognition that lower levels of bacteria still constitute an infection. So some of the labs are reporting slightly underneath this range, which is helpful. And a lot of doctors will still act on it and say, oh, it's a low grade infection. So that's good that that's starting to change, even from the lab side of things. However, there is in the updated 2019 recurrent uncomplicated UTI guidelines, that's published by both the Canadian Urology Association and American Urology Association. They've even actually recognized that an even lower cutoff is potentially appropriate in select patients. So labs won't even necessarily report down to this level. In the American units, it would be 10 to the power of 2, so 100 CFU per mil, and in Canada, greater than 10 to the power of 5 CFU per liter. So we're also looking, like I said, at that urinalysis and the urine microscopy. If we see nitrates in a urine sample, then that's again a pretty good indicator that they have a UTI, and it's usually a E. coli infection. So continuing on. Now, again, most of us are aware that E. coli is considered the majority to cause all UTIs. It is other bacteria, possibly even some yeast can trigger UTI symptoms. So, keep that in mind. I'm going to come back to referencing this later, but that's where it stands in terms of what's out there, on almost every website. It's usually E. coli. So looking at who this affects, women, doesn't matter age, race, ethnicity, education level, we're all potentially prone to getting recurrent UTI. 60% of women will have one in their lifetime. Usually women, 20 to 40% of women who will get one UTI will get another. And then about another quarter to half of those women will go on to recurrent long-term UTIs. UTI is the most common adult bacterial infection globally, which is, a good thing to know. And it is the most common ER diagnosis in women. Another kind of stat to throw in there is that potentially 30% of all recurrent UTI patients are complicated UTI. So even if you have a patient that, doesn't potentially look like they're a complicated patient, they do still need that full workup with their family doctor and urologist to determine if there is some sort of abnormality that is driving their UTIs. So brief coverage on the symptoms: acute onset of dysuria, so pain and burning with urination. This, of course, drives urinary urgency and frequency. Sometimes we see blood. Incontinence is also something that sometimes comes up with some patients. Incontinence at night, urinating at night, nocturia. In older adults, it is less clear of a symptom picture. However, usually dysuria is still predominant. There is more weakness and the potential for psychosis. If they have pre-existing health conditions or they already have dementia, then sometimes they aren't able to communicate that they've started with a UTI, and it will trigger a worsening of their psychosis. And so that's something to keep an eye out for in your elderly populations. There's a lot of other symptoms that aren't really as recognized, but when you have an infection, a lot of patients do report feeling fatigued, just general unwell, weak. Cloudy urine is another one that comes up a fair bit. Malodorous urine, vaginal burning, pelvic discomfort. and urine flow abnormalities. If we see that back pain, fever type of presentation, right, I think most of us know we automatically need to consider pyelonephritis, send to the ER, sepsis risk, right? That's something that would be out of our scope unless you're a medical doctor. Yeah, so as soon as you start to see that back pain, we got to consider the referral even before the fever happens, right? We don't want patients to get to that point. So basic pathogenesis, a uropathogenic bacteria adheres to the urethral lining and migrates up into the bladder using hooks or pillae, fimbriae, and then attached to the urothelium, infect the linings of the bladder, and the immune system activates, the urothelium sheds, and then it tries to heal. So that's just the basics. So now we're going to talk more about where these bacteria come from, right? How do they get there? And there's a couple of things to think about for this particular section. Most of the time it is a dysbiosis reinoculation type of situation. So the vaginal biome bacteria are there, or the gut biome, and the bacteria are unfortunately making their way to the urinary tract. Some of these bacteria are motile, right? E. coli is motile, it can move around. So as best a hygiene as you have, unfortunately, these bacteria are moving potentially. And then when it comes to recurrent UTI, right, one of the most common triggers is intercourse. So there's a mechanical inoculation that's moving, bacteria around. And unfortunately, some of it can end up in the urethra. So that dysbiosis reinoculation type of picture, right? Gut, skin, vaginal biome. And then we also do need to consider invasion from the sexual partner. So, their flora, their semen flora, their prostatic fluid, saliva, their skin, hands, gut biome as well. A lot of patients never, they've had multiple sexual partners, and then they have a new one, and that is the person that they get UTIs with, right? So we really have to be careful history takers in order to determine, whether or not their own biome is the problem, or whether or not they are potentially being reinfected by a partner. And the other part where bacteria can come from, which is more on the complicated UTI side, is if it is a persistent infection or an embedded infection within the bladder wall. Bacteria are, they're very smart. They want to survive and not be, wiped out of where they're trying to invade. So they have different mechanisms that are now coming to light through the research that shows that they can get into the urothelial cell and hide there. They can potentially make a biofilm. So that is another thing to consider, is if they have the pathogen, if they're harboring the pathogen in their bladder permanently, and it's going through quiescent and active stages. Always look out for relapse after antibiotic treatment, right? If a patient is on an antibiotic and within a few days of finishing the antibiotic, they start up with another infection, it's probably not invasion or reinoculation, it's just inadequate treatment. So we want to talk about the bladder biome as part of, the basis of pathogenesis as well. So in 2015, we got the confirmation through advanced molecular DNA testing that there is a urobiome. It's much less diverse and lower in abundance compared to the gut biome. About 600 different species have been identified in the bladder, and it does vary by gender, age, sexual habits, sexual partners, hormone status, cycle timing. In healthy cycling women who don't have a history of lower urinary tract symptoms, it's predominantly Lactobacillus crispatus is one of the most common. And women, and in asymptomatic controls as well. So again, women who don't have LUTs, E. coli, Enterococcus, Staph, Strep, Gardnerella, these are common to a small degree in these patient populations. So having a bit of E. coli in your bladder does not necessarily mean you've got a big problem. And we do see a lowering of diversity in the bladder biome with repeated antibiotic use. And the other part of this is that with these advanced DNA technologies that are now being utilized, we are seeing that recurrent UTI is frequently more polymicrobial than what we thought. So going back, touching on that standard urine culture, that standard urine culture was very well designed to pick up E. coli, grow E. coli. And of course, that means that it's going to preferentially do that. And what they're finding is that there's actually usually more than one organism that's a part of the community that is causing the infection in patients. So, and then of course, if a patient doesn't take the right antibiotic, you don't necessarily eradicate both. Okay. So from the urinary biome studies, this is kind of a neat, quick pictorial, right? Women who have no lower urinary tract symptoms, this big blue pie is the lactobacilli, so that's one of the most predominant. The black is actually, I believe, no growth. So some women don't really grow much at all. And then there's a little tiny sliver of E. coli, which is the yellow. And when we look at UTI patients, we see 50% is potentially E. coli. So that really challenges that previous, statement that I was speaking about earlier, where they assume, or they say 75% E. coli infections. I've heard 80, I've heard 90 before, when really in recurrent UTI, it could actually be lower, more like 50%. And there is a lot of other pathogens that show up. And then when we look at urge urinary incontinence and stress urinary incontinence, again, very different bladder biomes compared to healthy controls and compared to UTI. So the bladder biome studies are ongoing, and there's a new one out right now. So I think it's available. They're enrolling patients from the US to join. So you might want to look on Live UTI Free for that information. I know that's there's a big push to get thousands of women enrolled so we can learn more about the bladder biome and how it impacts, or learn more about it in general. So now let's talk about kind of more the underlying cause that, as holistic practitioners or functional medicine practitioners, that we want to focus on, right? We want to try and break the cycle so that patients can stop having these infections. So more research is still coming, but here's what we've got so far. We see a lowering of the diversity in the urinary biome will precede a UTI. So trigger number one, right? There's some sort of susceptibility that's created because there aren't enough space holding good bacteria to prevent a uropathogenic bloom from happening. So that's one of the most important things. We still don't have the research to support what 100% always triggers that lowering of diversity. Of course, antibiotics are going to be a concern. So we did get another study in 2002 by Warby, and they did show that the repeated treatment with antibiotics, although it's the treatment for UTI, does unfortunately trigger the dysbiosis, which then predisposes to another UTI. So it's one of these really tricky situations where our treatment is also what can set us up for another one. So not saying that we don't use them, not saying not to use antibiotics in these situations, but we do as a whole want to try to reduce the antibiotic use in our patients. So I'll talk about that more in a little while. We want to consider where the uropathogens are coming from. So the gut, and the vagina really need to be assessed to make sure that they have a healthy biome, and improving the biome in those areas, because the more dysbiosis that's seen in those areas, the more of a risk there is for recurrent UTI. We also see that there is an immune response that is a little bit skewed. So the Th2 response helps to heal the bladder lining after an infection. And what they find in recurrent UTI patients is that it's overactive. So it leads over time with each infection to more thickening of the bladder lining, which any sort of changes to that lining can actually predispose or make it easier for E. coli or another pathogen to adhere in the future. So there is this immune dysregulation that's happening. We also see with vitamin D3 deficiency that there is incomplete bladder healing after an E. coli infection, which then predisposes to having another infection. The bladder lining does heal slower than what most people, I think, realize. So when a patient has had an infection, their bladder lining it depends on how much damage, of course, happens during the infection, but it could take weeks and weeks for their bladder to really fully rebound after that infection. There's also other vitamins and mineral deficiencies that we're thinking about that is in the research, vitamin A and zinc, but more research needs to come from that end. Bacteria also are potentially working in pathogenesis, right? This goes back to that dysbiosis in these other areas. We're finding that, for example, Gardnerella can help E. coli adhere to the urothelium and trigger another UTI. And actually in that situation, that particular situation, it does increase the risk of getting a kidney infection in particular. So somehow Gardnerella is able to facilitate a worse infection potentially in patients. And then in general, I find any sort of chronic condition, chronic inflammation, anything that's affecting immune function is going to potentially increase the risk for UTIs. So, diabetes is a good example. I think a lot of people know that UTIs are frequent in diabetic populations. And it's not just because they have uncontrolled blood sugar, it's also because there's an immune dysfunction that's happening. And then, of course, low estrogen environment. So this is something that is commonly used now, right? Vagifem and various types of low dose estradiol to help reduce the risk of recurrent UTI in our postmenopausal women. And it's because it helps to improve that tissue integrity and in turn the lactobacilli levels, which then will outcompete the uropathogenic bacteria. All right, so here's the Warby, just a little summary on that one particular study that indicated that women who get recurrent UTIs are potentially caught in that vicious cycle with antibiotics given to eradicate it, but then predisposing them to another one. And repeated infections over time are not good, right? They can lead to the development of that thickened bladder lining, chronic inflammation in the bladder, and often women, in the IC-BPS world, it's about 50% of us had recurrent infections before we developed IC-BPS. So, there's changes that happen with repeated infections, which I think we know that in other parts of the body as well. So we do want to address this before, there's no statistic on what percentage of recurrent UTI patients could potentially go on to this, but it's a good reason to try and break the cycle earlier before it does become. A lot of my patients do end up telling me, when they tell me their story, they now it's starting to become symptoms in between infections, right? And that's always that really concerning piece, getting dry. I just have to take a pause for a second.
Hi, everyone. While we're waiting, just a quick reminder that please be sure to add in your questions when they do come up. We are tracking a list of some questions from this talk as well from some of the ones before that we never had time to get around to just because didn't have enough time, but hopefully you're all finding this interesting. And quite a few people had asked about getting the slides after, and Dr. Girard obviously was very gracious for offering to share the slides. And when the follow-up email comes out after the talk, please be sure to reply if it's something that you're interested in. I think Dr. Girard just probably went to grab a glass of water. Let's give her a couple minutes here.
Hi, I'm sorry about that.
No problem. I'm gonna disappear again.
Okay. So I can't promise that that's not going to happen again. I hope it doesn't. I'll just try to maybe talk a little bit slower. Just getting over another cold from my kindergarten kids. Okay, so So the patient experience. So first acute UTI, right? No big deal. Treated with antibiotics and hygiene advice often. And then patients go on to get recurrent UTIs, more antibiotics. They start to get vaginal infections, digestive problems, right? And a reduced quality of life. I'm just going to have to stop one quick sec and blow my nose. I will be right back.
All right, I'm back again, just to keep some entertainment going here. I have a question here, probably related to me for our business, but it says, can you take Utiva cranberry supplements or pills ongoing? Is there any downside to taking them long term? I could say that probably about 70% of our customers or patients that get referred to us are taking the cranberry pack supplement ongoing long term for what can I say, for prophylaxis, as opposed to going on, for example, a low dose antibiotic ongoing. So they are safe to take for a long time. The basis is still cranberry. I think Dr. Girard's back. I will disappear again.
Sorry about that, everyone. Okay. So just to acknowledge the patient impact that having recurrent UTI has, right? So as you know, as they're trying to treat this and they're getting these other infections, we see a reduced quality of life, loss of intimacy, a lot of fear, and a lot of trigger avoidance and frustration, a lot of unnecessary changes potentially. So, you know, there is a very big impact with this particular concern. So management wise, this is one of the things that is really important to me when I talk to practitioners, is we need actually 3 plans for these patients. We need a prevention plan, which is our most important. We need a corrective plan. And we also need an acute UTI plan, because when we're talking to patients, we want to set expectations that we're trying to reduce. Yes, we all hope for, you know, full elimination, but we want to set expectations reasonably. We're looking to reduce them over time, and we want long-term check-ins that are going to match the UTI frequency and working at identifying their triggers. So a lot of education and talking about, you know, triggers, then getting into a lot of specifics and reducing that antibiotic use if at all possible, reducing or eliminating. So getting on top of acute infections very early, having, you know, a full plan of how to treat a UTI without an antibiotic at the first sign of symptoms is really important, and it can help patients treat that lower bacterial count more effectively. And we're just, you know, we're working on their overall health, and we want to help them understand their body. So here's my awful list of all kinds of causes and triggers, as many as I could think of, just threw it all on one slide. So one of the most important and one of the most evidence-based things to do is to improve their hydration level. 2 liters of water a day is really helpful at reducing the risk of UTI. And we're looking at, you know, stress as a trigger, intercourse as a trigger, constipation as a trigger, you know, hemorrhoids, vaginal infections, antibiotics used for other reasons, historical antibiotic use, right? If they've been set up for dysbiosis before they even became sexually active, for example. Vaginal dryness, allergies, fragrances, right? Anything that creates immune changes or inflammation, kidney stones, right? Lots of different causes. And we do want to make sure these patients get the appropriate care and they're not just being given roundhouse after roundhouse of antibiotic. You know, they should be getting a referral to a urologist. They should be getting a pelvic ultrasound, checking for a residual volume, possibly a cystoscopy. Check them for a vaginal infection. Lots of patients have vaginal infections and don't have many symptoms. And then in terms of our side, right, we want to do nutrient testing, their vitamin D testing. We might want to do advanced testing on their for checking for gut dysbiosis. You know, I'm a big fan of Dutch hormone testing, looking at that estrogen piece. And you'd be surprised. There's lots of women in their 30s that have low estrogen already. So that's potentially a contributing factor. And, you know, we've got lots of details that you want to collect. You want to find out about their antibiotic use, what antibiotic was given, how did it make them feel, did it resolve all their symptoms, and you want to go through all, and same with supplements, right? What supplements have they tried? How much did they take? How long did they take it? What was the effect of that? So just a lot of really careful case taking to determine the best course forward for creating an individualized treatment plan for them. Okay, so as naturopaths, right, we talk a lot about the therapeutic order. So we've got our lifestyle, then we want to try and prevent. We want to use those anti-adherents, which I'm going to talk about more shortly. And then once we start seeing an acute UTI situation, we're switching to, our antimicrobial herbs. If those aren't working, then we go up to the antibiotics, antiseptics. If you haven't heard of Hiprex, it's something to look into. Not an antibiotic, but is a drug antiseptic that passes into the urine and basically sterilizes the urine. But it only works with acidic urine. So a little bit tricky to use sometimes. And then we want to consider the prophylactic antibiotics in, more severe cases where we just can't seem to get those infections under control, or potentially prophylaxis after triggers like intimacy. Okay, so prevention, right? An ounce of prevention is worth a pound of cure. So proanthocyanidins are definitely my favorite tool for prevention in my practice. I see a really excellent effect with using the 36 milligrams PACs. Before I used this, I kind of I wasn't really using cranberry because I didn't really find that the raw cranberry extracts, even personally, I didn't really find that they helped. And that's what I hear from my patients as well. Maybe helped, maybe did, but often not. But once I was introduced to the a product that was focused on proanthocyanidins, I saw a much improved, much lower rate of recurrence when I started getting patients onto that type of product. It has a longer half-life, which I really like. It gives a longer duration of protection, targets multiple organisms, very advantageous, right? Our E. coli our D-mannose really only functions against E. coli. So, and we do want to consider doubling the PACs, that 36 milligram dose after intercourse. And we want to choose a product that is third-party tested, really, really important. Most products are not third-party tested to confirm the amount of PACs, and they may not disclose. What they put on their label might not be 100% accurate. And then also how the product is prepared. We want to have a product that has soluble PACs so that we can absorb them and they pass through into the urinary tract. If there are certain things added to the capsule, it can bind up the soluble PACs and make them insoluble so that we don't end up getting the benefit. And although there is proanthocyanidins in other things, we really want a very specific type of proanthocyanidin, type A. Grape and green tea and things like that, they have a different type of proanthocyanidin, and that doesn't really have an anti-adhesive effect the way that the type A does. So Utiva is very commonly used here in Canada. That's the main product that I'm using with patients, and really happy with it so far. So, and I think they recently were voted the most popular proanthocyanidin product by physicians. So now some of the research, right? Cranberry research is kind of all over the map. And again, it's because it often doesn't hone in on that concentrated PAC dose. So this is a really good study that was published in the Canadian Urological Association. Complicated UTI patients, right? So more difficult patients to treat. And we saw a 60% reduction in uropathogenic bacteria found. And no adverse effects, very important, and actually saw a 30% decrease in antibiotic resistant organisms. So it actually helped the organisms deprogram themselves from their resistance patterns over time, which is great, right? And that was just a 36 milligram one time a day for 6 months. And then there was another study that I stumbled across recently, and it was a double-blind controlled trial, and they were given the type A PACs at the 36 milligram dose, and again, they saw significantly fewer UTIs, lower colony counts on culture, And one of the purposes of the study was that they wanted products to be third-party tested using the DMAC/A2 testing, and that's what they really found was important, is that it had to be confirmed with that high dose PAC content. So how does it work? It binds to the P. fimbriae, fills up the receptor on the bacteria, so then that receptor can't bind to the mannose insensitive glycolipid receptor on the urothelium. Another reason I do in particular like this product is because it's low in sugar and low in acids. So, just in case you get those patients that also have IC, bladder pain syndrome, cranberry is traditionally no, it will aggravate them, and it's often because of that acid content. So this particular product, they do make that extra effort to try and take out some of those acids, so it might be better tolerated. I would say if they were very symptomatic, I would be very careful still, but if they were fairly well managed IC patient, they may be able to tolerate it, and then prevent, if they're the IC patient that also gets recurrent UTIs, right? Then that might be a good option for them. Because if you get a acute UTI while you have IC, it just makes everything worse. So anyways, when we look at other brands of just raw cranberry extract, often they have 5 milligrams or less of PACs. Sometimes it's too low to detect, or essentially it's shot in the dark whether or not it's going to have any in it, well, or enough to really have a treatment effect. And lots of other studies out there that show that cranberry, it does work. Cranberry PACs work. And I think I mentioned, or I'll mention it now, but we do want to double it after intercourse for 2 days. Any trigger really. When patients, travel is a trigger, I'll have them double it then too. The mannose is also great, but I use it more for acute infections, a 2-gram dose, and I do it quite frequently. It primarily works against E. coli. How does D-mannose work? It binds to the type 1 fimbriae on E. coli. I hope I don't need you to jump back in, Derek. Okay, lactobacilli, mixed study results, but I think as we hone in on the best species, we're going to see this get more research, positive research around it. Lactobacillus crispatus has more research coming right now, and right now it's looking to be potentially one of the most promising for reducing recurrent UTI. Vaginal estrogen. So according to the 2019 guidelines, it did bring in perimenopausal women into this. So we do want to be thinking about that vaginal estrogen for perimenopausal and postmenopausal, even if they're greater than 10 years past menopause. If they're having atrophic vaginitis, GSM, then we do want to still potentially start local estradiol or estriol in order to slow down the recurrent UTIs that they're experiencing. And then we also might want to consider topical bias. It's actually right in the news right now. There's a bit of a push to start looking at treating with more HRT for women that are experiencing menopausal symptoms, which recurrent UTI is among them. And topically, I mean. So what does estrogen do? It thickens the lining of both the bladder and the vagina, and it promotes the growth of lactobacilli. Those lactobacilli, they can then fight off, uropathogenic bacteria or prevent uropathogenic bacteria from adhering. And Euroimmune. So I always like to mention, in Canada, we are potentially getting Euroimmune this summer. We've been waiting already many years, and it's a urinary vaccine that's oral, and it just helps to improve the immune resilience against about 5 different bacteria. So that is also something that we're hoping to see approved very shortly to help reduce recurrent UTI. I think right now the study is showing 80% success rate with that. So that's a pretty big deal, and that's coming up soon. All right, little summary. I think we've covered most of this. A quick case. So UTI primarily from intercourse. We have, 24-year-old female, UTI quite frequently or monthly even since becoming sexually active. They start usually 24 hours later. If symptoms start within, a few hours, we have to think more pelvic floor. That's kind of a differentiating factor. Right? Bacteria need time to divide, and E. coli can replicate as quick as every 20 minutes. So you can see how quickly a patient could get an infection, 24, 48 hours later. And she actually didn't have any cultures done, but she was given lots of antibiotics and they always cleared the infection. She had chronic constipation since she was a baby. She had tried a few supplements, cranberry supplements, without much success. So I put her on the 36 milligrams of PACs. We had D-mannose for acute treatment if something flared up, magnesium to start resolving her constipation, and fiber, and lots of good gut repair probiotics with a female focus, lots of lactobacilli, 50 billion, and lots of water. And right now I'm still following her, and here we do little check-ins and everything's still growing great. So, and there's just she's had a couple little flare-ups that were managed with the D-mannose and a little bit of baking soda. So sometimes I'll help use baking soda to soothe the urinary tract as well. And don't be afraid to use some Advil. These UTIs are very painful and patients are just desperate to get out of pain. So using Advil is absolutely will help patients feel more comfortable while they're waiting for things to work. Here's another very common presentation, UTI in a postmenopausal woman. So a 73-year-old female, she had developed recurrent UTIs. She had about 6 in 5 months, and some culturing, some not culturing, but they were responsive to antibiotics. But by the second or third infection, I believe, she started getting continuous symptoms in between to a lesser degree, up 2 to 6 times a night. And if the antibiotic did help, her symptoms were returning quite quickly, full force within 3 days. She was very fearful to have intercourse, really fearful. It had really had shaken her. And she had tried a couple things, cranberry product, a little bit of probiotic, D-mannose, and not really much had happened. She hadn't really stabilized it. And instead what we did was the 36 milligrams of PACs. We brought down her inflammation. That continuous symptomology in between infections could be just residual inflammation. So curcumin, omega-3s, high dose. She was low in vitamin D. We upped her vitamin D aggressively. Took out bladder irritants to make sure that it gave her bladder a chance to rest, like coffee. And we did some antimicrobial therapy with juniper and usnea and hydrastis, and lots of water and some immune work, and still 2+ years without any infections. So that was another really good one. We did trial estriol with her, but she didn't tolerate it at her age. It created some pelvic pressure that she didn't like. So those are 2 very common patients. And yeah, I'll send it back over to you, Derek. Sorry, I went a little bit longer because of the coughing and stuff and slowing down what I'm saying.
Hey, that was great. It actually, I wasn't going to interrupt you because of the pauses. I was just thinking, let's just let it keep going. I'm sure we've had a lot of good questions and a lot of comments about, how everyone's appreciating the knowledge that you're sharing and all the details. So it's very positive feedback already amongst the questions. So, okay, I'm going to fire some questions. We have about 15, 20 questions here, so we'll try and get through them quick. Okay.
Can I open up the chat too, and will I be able to see them there too?
You can, but I've also copied them to organize them to ask you.
Okay, perfect.
Okay, we'll start from the beginning here. What normal flora are found in urine, since they now realize that bladders are not sterile?
So predominantly it's lactobacilli, different types of lactobacilli, but it's also Gardnerella, actinomyces. There's a little bit E. coli. There's actually can be a moderate amount of Enterococcus, Streptococcus, Staphylococcus. It can be quite diverse potentially in patients.
Okay, thank you. What is Th2? You mentioned it in the what contributes to the development of recurrent UTIs.
Yeah, so the Th2 response is a part of our immune system. It tends to be more, I think when we learn about it in school, it's more to do with the allergy side of things. It's just how that type of a part of the immune system responds to certain immune pressures. So, for example, like I said, allergies, the immune system will activate that branch, the Th2 response, in order to help manage that, that identified not pathogen, but antigen. And it just happens that in the bladder, what they've found is that it's more of a Th2 response in the bladder. So it's more about balancing away from the Th2 response. So there are products out there that do that. They balance. I believe it's Pure Encapsulations has products that help to balance that response. So you might want to be thinking about that for patients.
Do you, just to dive a bit more, do you have is there a specific type of supplement that is recommended to do the balancing for the Th2?
Yeah, well, there's also probiotics that skew more to the Th1. So, patient or practitioners can look for that. But the product that I'm referencing, I think it's called Th1 Response by Pure Encapsulations.
Okay, thanks.
Mhm.
Next question. A customer said she uses lidocaine in the vag area to help with pain. Do you have any thoughts on that?
Well, it's really important to manage pain. And lidocaine, of all the types of painkillers out there, is, pretty direct, right? You apply it, you get pain relief, and then it wears off. It's not usually associated with too many side effects, but it is masking something that's going on, right? So you do want to look to see if she potentially has a pathogen that hasn't been detected. And, sometimes you do want to look for something like ureaplasma in this case, which is an infection that won't show up on standard types of culturing. So you do need to use more of like an advanced DNA technology, or I think it is accessible to test it with a special type of culture through regular labs as well. We do have access to it here in Ontario through urine, but I know gynecologists can swab for it as well vaginally. And a urethral swab is actually even the best way to detect it. But yeah, you want to get to the bottom of that particular patient's concern and what's causing their pain.
Okay, thank you. This one came up a couple times, so I combined the questions here. We
Okay.
have also been advised that inserting a garlic clove vaginally will help with UTIs. Any thoughts on that? And related to it, I've heard garlic for yeast infections, but maybe UTIs as well. So kind of a
Okay.
combo.
Well, it's definitely a subset of my patients where they have a vaginal infection and it presents almost entirely as a UTI. So we do want to be really careful to make sure we're treating a vaginal infection if we suspect that that's going on. So the garlic is more about treating the vaginal infection as opposed to a UTI. If a patient had a perfect vaginal biome, it's not something I would utilize in those patient populations. But if we have any sort of unusual vaginal discharge, or itchiness or dryness, a positive swab, or if they've done advanced vaginal biome testing, and then we do see that there is a dysbiosis there, then yeah, that's potentially a way to treat it. However, I don't use it a whole lot in practice. I'll be honest. I do lean towards other therapies to correct a vaginal biome.
Okay, thank you. What nutrient testing do you use with patients?
Um, so I mean, when I'm referring to nutrient testing, a lot of it is the B12, or sorry, not B12, vitamin D, but also looking at ferritin and B12. I do like to get that mini oat test on my Dutch reports to check for, B6 as well. Not all patients can do all the advanced testing. An oat test is great if patients can afford it, but it's usually lower on my list for these patients. That that estradiol, getting that information is often more important to me, or to do, or for patients to do more of the advanced DNA testing for the biomes, for the bladder and for the for the vaginal canal or the gut, right?
Okay. This question is kind of product specific, but love your opinion here. How does 36 milligrams a pack compare to other well-known concentrated cranberry extracts such as Cranmax, which is supposedly equivalent to multiple cups of cranberry juice per capsule?
Ooh, Cranmax. See, now I wouldn't be an expert on the amount of PACs that are in these different products. So unless they're disclosing the amount of PACs per whatever dose, and then they also have a third party testing, I, you know, I'm not always 100% confident that that's going to deliver the same rate of reduction that what I'm hoping for. Yeah, I mean, if a patient has used it in the past and they've been really successful using it, then that's still something to consider for sure.
Just to add to that, we're a huge proponent of like, hey, if something's working, then why change it? But we have also measured multiple, like the packs in multiple brands across Canada and the US. Unless it's calling out 36 milligrams of packs and how they measure it, it doesn't matter what the brand of cranberry extract it is, it would come out low typically, unless they call it out, like you were saying, Dr. Girard.
Yeah.
Okay. Both partners, this is a bit of a statement, but I'm assuming it's just like a question as well. Both
Sure.
partners to wash, bathe, or shower prior to intercourse. And I'm
Yeah.
assuming that means that this would be minimizing your chances of infection.
Yes. So this is a particular behavioral habit that I'm not as fond of because it's in my patients, when I ask them, the people that are doing this, and I say, do you think it's made a difference? Almost all of them always say no, but they're doing it anyways because somebody has said it along the way. And the research around this particular behavior isn't great either. I would say if they've had UTIs with skin bacteria, staph, or maybe strep, then I would maybe consider it that might be a way to mitigate and reduce the load of bacteria on their skin before intercourse. But I don't necessarily like to promote all of the behavioral habits. I mean, peeing after intercourse, I should have mentioned it before, really key, really important to flush the urinary tract within a short period of time, not a half an hour later, not an hour later, not waking up hours later. So that is one that I'm wholeheartedly, is research based. But yeah, the showering only if it's proven to be effective for them. But I definitely never recommend that to my patients unless I'm seeing a lot of staph infections.
That might be a very big lifestyle modification.
Yeah. Yeah, and there's already so much fear, right? And now it's like everybody has to wash, and it's we
Got
don't
it.
need to be afraid of all of the bacteria, right? We need to fix the biome. We need to have healthier biomes.
Mhm. Okay. When would you do 1,000 milligrams of D-mannose versus 2,000? Would 1,000 milligrams be daily for prevention versus 2,000 milligrams for treatment and after intercourse, travel, or sex triggers?
I pretty much always do 2000. I find that the 1000 has a higher failure rate. So I pretty much always do two. And when it's an active infection, I'll dose that D-mannose every 3 to 5 hours. So really increasing it up there to help flush out the bacteria because it has a very short half-life. It spills into the urine quite quickly. So we do want to keep exposing the bladder to it during an active infection. However, I wouldn't use D-mannose alone for an active infection unless it's worked for a patient in the past consistently and they're getting on top of that infection right away. So,
Okay. Someone had missed the strain of lactobacillus that was recommended. Can you remind me?
yeah, lactobacillus crispatus. And it's very difficult to find in supplements. I've had to scour so many supplements to find crispatus, and there's a couple out there. Culturel Women's Healthy Balance has crispatus, Gensai, rhamnosus, and a fourth one in there. All really good colonizer, like positive colonizers of the vaginal tract and prevents uropathogens.
And when you are looking for these the probiotics, just I'm kind of adding to that, do you recommend are these oral or suppositories?
So I usually do oral, but then I might do a round of a suppository if I see any sign of vaginal dysbiosis. Different, people come, having different histories. If a patient has had a lot of antibiotic use and they've got vaginal dryness, maybe that's all they've got, then doing a round of 7 days of vaginal probiotic just to get a good dose of lactobacilli there is not a bad idea. But overall, you do want to be seeding it from the gut, which takes 3 months at least to have that impact to help change that flora.
Okay.
So both.
It is 8:30 right now, but I have 5 questions left. If you're okay, I'm just going to go through these last 5 questions.
Yeah, I'm okay.
Okay. And would you recommend long-term lactobacillus use for postmenopausal women due to low estrogen?
Orally, yes, absolutely. And there's lots of products out there that do have that. We've got the Metagenics Ultra Women's Flora, we've got Femdophilus, we've got Pro Refresh B or whatever that, there's lots of different brands out there. But yes, that's important in my practice is to beef up those lactobacilli levels.
Okay. A bunch of people ask this question. How do you
Mhm.
take baking soda?
Yeah,
How do you
that
recommend the
comes up a
use?
lot.
Yeah.
Yeah, so one thing that didn't come up in my presentation that I should have mentioned was that I do like to teach patients how to use urinalysis strips. They're really cheap on Amazon, $15 for 50. So it's a really good way to help patients learn to self-monitor. So I use baking soda to soothe the urinary tract. I'm getting them to kind of keep an eye on that pH tile and getting them to have a pH between 7 and 8.5 to soothe the urinary tract. There's some research that shows that baking soda slows the growth of E. coli as well. So it's kind of a bit of a double benefit there. If you decide to use uva ursi, you do want to have alkaline urine as well. D-mannose may also work better in alkaline urine. So I do use baking soda a lot. Most patients need about a half a teaspoon twice a day. You want to have it in a big glass of water. I wouldn't be using it in patients that have high blood pressure because of the sodium content. And there could be patients that need more to alkalize their urine. To get it up there above that 7. And I usually tell patients if they get above 8.5, quit, skip that next dose, couple doses of baking soda until that pH comes back down a bit.
Okay. And the urine analysis dipsticks you're talking about, that's for testing pH. That's what you're referring to here.
Yeah.
Okay. You mentioned in patient 1, she was taking a 10 billion probiotic. Do you see any more aggravations in patients who take probiotics or higher dose probiotics over time? Any probiotic that you have found help recurrent UTI? So it's kind of like the question before, but
yeah, sorry, there's a mosquito buzzing around if you see me like swatting. So there is a risk of having too much lactobacilli. I would say in premenopausal women who are cycling, women that have robust estrogen levels, there is a risk that lactobacilli can overgrow and then cause a different problem. So I usually will use a higher dose lactobacilli probiotic for a period of time, 3 to 6 months, and then I'll start changing it up and lowering the dose. It is going to depend on their history with antibiotic use. We do have a study that shows, for an entire year after a 7-day course of Cipro, we have a dysbiosis. So, you're going to have to tailor that based on how much antibiotics they have used. And then, yes, I generally go down to lower doses for maintenance. And Lactobacillus crispatus is really important. I do really like Reuteri and Rhamnosus strains to be in the products as well. Did I cover all those questions?
I believe so, yes.
Okay.
More about the probiotic strains. All right, 2 last questions here. Will a high calcium content circulating in the blood contribute to UTIs or vaginal infections?
Not that I have seen, but maybe that's an area that I haven't forayed into. Calcium is often used to buffer urine. Like in IC BPS patients, we use a product called Preleaf to take the acidity out of food, and that's usually a positive thing. Calcium in the gut also helps to bind up oxalates. We didn't even touch on oxalates, but that can also irritate a patient's urinary tract. So usually I think high calcium doesn't have a negative consequence, if not a positive impact.
Okay.
Oh, well, I have one caveat to that. If they have
Yep.
pelvic floor dysfunction, high calcium could make more spastic muscles. So possibly along that line, but yeah, not that I've seen them in patient population.
Okay. All right. Last question. Back to probiotics again.
Mhm.
Prebiotics. Are there prebiotics sufficient to increase lactobacillus alone? Which prebiotics would you recommend to assist in increasing the lacto if needed, if possible?
Yeah. So, I mean, I don't use a lot of supplements for prebiotics, but I do a lot of talk. I do talk a lot with patients about increasing their vegetable intake, eating more diversely. Not just having a handful of vegetables. It is a problem, right? That a lot of patients aren't eating enough vegetables. Vegetables in themselves will help to alkalize the urinary tract. So there's just so many benefits. Yeah, so I tend to lean into food for prebiotics and diversity from that perspective.
Okay. Well, hey, Dr. Girard, listen, we've gone over here in time and I appreciate you staying on a bit longer. Just want to mention to anyone that if you have patients in Ontario interested in further investigation into their bladder health, Dr. Girard's the right person to go to. And, we will be following up with some information after as well. And her contacts and information, if needed, will be there. And you can always request for us to put you in touch with her as well. So, Dr. Girard, thank you very much for your time today.
Yes, thank you so much, Derek. I really enjoyed it, and yeah, if you got questions, just you can shoot me an email. You can find my email on my website.
Sounds good. And for those sticking around, we're still going to do the raffle. Hey, Dr. Girard, have a great night. Thank you very much.
Okay. Enjoy the raffle. Bye.
Okay, thanks.